Today, we are shifting our lens. We often view reproductive health, RH, strictly through a medical or human rights perspective. However, to effectively manage these services, we must understand them as a market. This session will dissect the reproductive health market. We aren't looking at patients and doctors in isolation. We are looking at the ecosystem of supply and demand, the exchange of value, and the massive external forces like laws, money, and culture that dictate whether a woman can access a contraceptive pill or a couple can access IVF. Let's begin. First, we must define the system. A reproductive health market is not just a clinic. Definition: it is the entire ecosystem where goods, like condoms, and services, like counseling, are produced, distributed, and consumed. It encompasses the factory that manufactures the IUD, the supply chain that delivers it, the insurance company that pays for it, and the individual that uses it. Includes. The scope is vast. It covers contraceptives, the commodities market for prevention, fertility and ART, a rapidly growing, high-cost sector for those struggling to conceive. Maternal health services, the essential time-critical market for pregnancy and birth. STI/STD management, the market for diagnostics and treatments. Menstrual health products, a consumer goods market critical for dignity and hygiene. Reproductive cancer screening, preventative services like pap smears and mammograms. Understanding this range helps us see that we are dealing with a mix of essential public goods, like maternal care, and consumer retail products like menstrual pads. Who operates in this space? This is a mixed health system involving 5 distinct actors. Public sector, government hospitals and clinics. Their role is typically to provide a safety net, offering subsidized care to ensure equity, although they are often resource-constrained. Private sector. For-profit clinics, pharmaceutical companies, and private insurers. They drive innovation and efficiency, but prioritize the ability to pay, often catering to wealthier segments. NGOs, non-governmental organizations, often step in where markets fail, providing aid in conflict zones or subsidized services for the poor, filling the gaps left by the public and private sectors. Community. This includes community health workers, CHWs, and grassroots networks. They are the last-mile distributors, bringing trusted information and basic commodities to the most remote doorsteps. And digital providers, the newest actor. Telemedicine apps and e-pharmacies are disrupting the traditional model by removing the physical location from the equation. Why do we study market dynamics in health? Because market failures cost lives, determines access, affordability, and quality. If the market is inefficient, supply chains break, stockouts. In a monopolistic market, prices tend to spike. The structure of the market directly decides if care is within reach. It shapes equity. A purely free market naturally serves the rich. Studying this helps us understand why maternal mortality is higher in low-income brackets. It exposes where the market fails the vulnerable. It influences innovation. Markets follow money. A healthy market signals to investors that they should fund new technologies, like better contraceptives or cheaper IVF. If the market is stagnant, innovation stops. No market exists in a vacuum. 5 external forces heavily buffet the RH market. You can think of these as the rules of the game. Regulatory climate, what is legally allowed. Technological advances, what is medically possible. Economic barriers, what is financially feasible. Socio-cultural norms, what is socially acceptable. And competitive landscape, who is fighting for the consumer. Let's break these down one by one. The regulatory climate is the gatekeeper. Key regulatory influences. Abortion laws. Legality is binary, legal or illegal, but regulation is nuanced. Gestational limits or provider requirements can strangle the supply of services even where they are technically legal. Insurance exclusions. If the government doesn't mandate insurance coverage for fertility or contraception, Demand drops because patients can't afford it on out-of-pocket. ART regulations. Assisted reproductive technology is heavily policed. Laws on surrogacy or egg donation dictate whether a fertility market can even exist in a country. Adolescent consent. Laws determining if a minor needs parental permission for STI testing or contraception directly control whether adolescents can enter the market as consumers. Impact. These laws artificially manipulate availability, supply, and price, and they can halt innovation if the regulatory burden is too high. Technology is the great disruptor. It expands the market's capabilities for selling. Transforming RH markets. IVF and ICSI. Advanced procedures like intracytoplasmic sperm injection, ICSI, have created a market for treating male infertility that didn't exist 30 years ago. Genetic testing. Pre-implantation screening, PGTA, has turned embryos into information-rich entities, creating a high-end niche market for healthy pregnancies. Tele-SRH. Virtual consultations enable services to transcend geographic borders, thereby expanding market reach to rural areas. AI-based diagnostics. AI is making screening, like reading mammograms, cheaper and faster. Impact. While this expands access, notice the caveat. It increases costs. High tech usually means high price, potentially widening the gap between the rich and poor. Economics is the filter that decides who participates. Persistent economic challenges. Out-of-pocket maternal care. In many developing markets, childbirth is a cash transaction. This is a massive barrier that deters women from seeking skilled care. Insurance exclusions. When insurance views fertility or contraception as lifestyle choices rather than health needs, costs are passed entirely to the consumer. High cost of advanced fertility. IVF is one of the most expensive medical services, often requiring upfront cash, making it an elite market. Impact. This creates unequal access. The market becomes segmented by income. Excellent care for the wealthy and substandard or no care for the poor. Culture acts as the invisible hand, suppressing or boosting demand. Strong determinants. Stigma. If buying condoms or getting an STI test labels you as promiscuous, you won't participate in the market. Shame suppresses demand. Gender norms. In many societies, men control household finances. If a woman wants contraception but her husband refuses to pay, the market transaction cannot happen. Religious constraints. Religious opposition to contraception or abortion can lead to consumer boycotts or provider refusals. Conscientious objection. Impact. These norms suppress demand and delay care. Market growth is impossible if the culture tells people not to use the product.
Who is competing? The nature of the player determines the nature of the service. Types of RH players. Public facilities. They compete on access, free or low cost, but often lose on experience, long wait times. Private providers, they compete on service quality and speed, targeting those willing to pay for comfort. NGOs, they fill the market failure gaps, competing on trust and mission. Digital platforms, they compete on convenience and anonymity. Competition influences. The mix of these players determines the price, more competition usually lowers the price, and the service mix, what is actually offered to the public. We've looked outside, now let's look inside. A provider's internal health determines its market power. Organizational capacity. Does the clinic physically have the beds, the sterile theaters, and the labs to handle patient volume? Internal factors. Workforce. The global shortage of midwives and embryologists is a massive internal constraint. You cannot sell a service if you lack the staff to perform it. Diagnostic capability. Do they have the ultrasound machines or genetic labs required for modern care? Impact. These internal factors dictate the cost structure, how expensive it is to run the clinic, and the quality, which ultimately determines the pricing strategy. Let's summarize the system dynamics. Key market dynamics. The market is fluid, not static. Influenced by consumer behavior. Are patients becoming more proactive? Policy shifts. Is the government investing or cutting back? Tech innovation. Is a new app changing how we prescribe? Supply chain. Can we actually get the pills to the clinic? Insurance. Who is paying? These forces constantly push and pull the market, creating trends we call drivers, accelerators, and restraints, brakes. We will now analyze the specific forces that accelerate growth, drivers, and those that slow it down, restraints. Drivers examples include government awareness campaigns, the biological ticking clock driving fertility demand, and better access to pills. Restraints examples include cultural taboos, the high cost of IVF, and broken rural infrastructure. Let's dive into the drivers first. The strongest accelerator is often the government. Government-supported education. When a government runs a public health campaign, for example on HIV prevention, it essentially offers free marketing for the service, driving up demand. Integration into UHC. When SRH is added to universal health coverage schemes, the financial barrier is removed. The government becomes the primary customer, stabilizing the market. School-based sex education. This creates a future generation of informed consumers who know what services they need. Reduced stigma. As awareness rises, shame drops, leading to increased service-seeking behavior. A specific boom is happening in the fertility sector. Delayed childbearing. As people prioritize careers and marry later, they encounter age-related infertility. This biological reality drives them to the market. Lifestyle factors. Stress, diet, and environmental factors are increasing infertility rates globally. High cost. Despite the cost, the desire for a child is inelastic. People are willing to pay high amounts, making this a lucrative market segment. Growth of IVF and egg freezing. We are seeing the commercialization of hope. Egg freezing is now marketed to young women as fertility insurance. In the contraception market, accessibility is the main driver. Wide method mix. We have moved beyond just the pill. We now market patches, rings, implants, and IUDs. More options mean more consumers find a product that fits them. Expansion through pharmacies. Allowing pharmacists to prescribe task shifting removes the doctor from the equation, making the purchase much easier. Rising urban demand. Urban women balancing work and life are the primary drivers of demand for modern contraception. Supports autonomy. Ultimately, this market growth is driven by the desire for economic and bodily autonomy. However, growth is not guaranteed. We face three massive breaks or restraints: cultural and social taboos, the psychological barrier; high cost, the financial barrier; and weak rural systems, the logistical barrier. Let's analyze the impact of each. The first break is cultural. Silence. In many places, sex is simply not discussed. This culture of silence means people suffer in isolation rather than entering the market for help. Shame, infertility, or STIs are often viewed as divine punishment or personal failure, leading to secrecy. Restrictive norms. If a society believes adolescents should not be sexual, they will actively block adolescents from accessing services. Impact. This results in lower demand. The market shrinks because potential customers are too afraid or ashamed to show up. The second break is cost. This is particularly true for advanced technology. Unaffordability. Procedures like IVF or donor egg cycles can cost tens of thousands of dollars. This prices out the vast majority of the global population. Inconsistent insurance. Without a third-party payer, insurance, or government, the market is limited to cash payers only. Burden. This creates a heavy economic burden on the middle class who may go into debt to pay for care. Impact. This leads to market stagnation. You cannot scale a business if only the top 1% can afford your product. The final break is physical infrastructure. Shortage of providers. You can market a service all you want, but if there is no doctor in the rural village, there is no market. Diagnostic gaps. If a rural clinic can't test for an STI, it can't treat it. The market chain is broken. Poor transport. If the road is washed out, the patient can't reach the supply. Impact. This limits market penetration. Companies and governments struggle to extend the market beyond major cities, leaving rural populations with poor outcomes. To close, let's reflect on how these forces play out in reality. Which external force most strongly shapes the SRH market in your country? Is it the law, regulation, or the culture, social norms? How will technology change RH markets in the next decade? Will AI and apps bridge the rural divide or just make care more expensive? What policy reforms could help? If cost is a restraint, is the solution mandatory insurance? If culture is a restraint, is the solution education? Thank you for your attention. This concludes our overview of the reproductive health market.